Welcome, You are joining our first Lunch and Learn series on maternal and child health in a four-part series. Today we'll be focusing on cultural humility. I'm Dr. Ramona Danielson. I'm an assistant professor in the NDSU Department of Public Health, and I teach in the maternal and child health subplan. And I would like to introduce you to Danielle Ginther, who is going to be our presenter today.
Well, hello and welcome, and thank you for joining us for our first part in our Maternal and Child Health Lunch and Learn series. My name is Danielle Ginther. I am a recent North Dakota State University Masters of Public Health graduate with a specialty in maternal and child health. I picked this my last year because I was really motivated by my practicum experience at Families Flourishing North Dakota, which was formerly Prevent Child Abuse North Dakota. And I also spent my research time for my master's thesis looking at postpartum depression in rural populations. So I'm just really excited to be here today. Want to thank you all again for being here. We're still getting a couple people hopping in, but I will go ahead and start our presentation. I just want to remind everyone that this is a series, so we do have 3 other events that will be happening next week. Next Tuesday at the same time, we'll have Family Diverse Structures and the Importance of Fathers. On September 17th will be ACEs and Trauma-Informed Approaches. And then on September 24th, we will be doing Framing and Public Health Communication. So our learning objectives for today will be, I will be able to differentiate between cultural competencies and cultural humility. I will understand the importance of cultural humility within MCH populations. I will learn of ways that cultural humility has been practiced within the maternal and child health field, and I will be able to understand how to practice cultural humility within maternal and child health populations and clients. I do want to make a note that also leading us through our series and the presentation today is our maternal and child health leadership competencies. So these were created in 2007 and have further been revised, and they consist of 12 foundational and advanced skills essential for the maternal and child health workforce. These competencies are used as training tools and as evaluation to understand where the maternal and child health workforce is at. So today, those competencies that we are focusing on is self-reflection, communication, diversity, equity, inclusion, and accessibility, and then honoring lived experience. So moving right on to our first learning objective is I will understand the concept of cultural humility. And in order to understand the concept of cultural humility, I want to start by kind of giving you the definition of cultural competence, which many of us are very aware of and have been doing this in our field for quite some time. So cultural competence is a set of congruent behaviors, attitudes, and policies that come together in a system agency or among professionals and enable that system, agency, or those professionals to work effectively in cross-cultural situations. When cultural competence was originally defined in 1989, it was noted that an agency can have cultural competency as a goal, but there would always be room for growth. However, we have seen as we have continued training that we have kind of lost that idea of growing within cultural competency, and that there's a lot of variability between these trainings, and there's a lot of assumption of what the audience looks like when we're teaching these things, and then the connotation that it can be mastered. So we have moved to a term that better encompasses what we actually want to get out of what our cultural competent training, which is cultural humility. And the definition of cultural humility is an orientation towards caring for one's patients that is based on self-reflection and assessment, appreciation of patients' expertise on the social and cultural context of their lives, openness to establishing power balance relationships with patients, and a lifelong dedication to learning. I know it's a very long definition, but there's so many words we use to talk about a professional's ability to recognize and accept and respect culture in several contexts. And we have settled on cultural humility because it best encompasses that whole picture. So why did we shift? Because cultural competency kind of suggests mastery in its own terminology and suggesting a way that we can do so, though there's never going to be enough time in our lives to ever master a single culture. Cultural humility focuses on self-awareness, reflection, and patient and population as experts in their own cultures and the contexts that shape their own worldview. Cultural humility also has a focus in power imbalances and how to work toward leveling these dynamics within your work. The nice thing about cultural humility is that it does not require expertise. It cultivates empathy in your work. It acknowledges individuality, which is a very big thing in the United States culture. There's an emphasis on connection, acknowledges other people's history, and it recognizes that we move between cultures and that many of us are a part of a lot of different groups that require us to shift every now and then. So what does this look like? A practitioner who meets a client or a community using cultural competence will come in and examine the issue, then implements a solution that they assume will fix or alleviate the issue. However, they do this process without the input of the client or the community, which at that point, it's really hard, especially if you're not part of that community, to know if you are doing the right thing for them. However, a practitioner who comes in, who meets with a client or a community using cultural humility, they would ask the client or the community what they find the most pressing issues or problems, and are there then collaborate to find the best solution. The biggest difference between cultural competence and cultural humility is that cultural humility is more conversational and establishes genuine relationships. So let's talk about things that color our own worldview. So I want to start with these definitions of a dominant versus a subordinate group. Dominant groups in our cultures consider that those groups which are more socially acceptable or privileged within society, and they usually have more access to things like education, money, power, and among other resources. Dominant groups are often the groups which create the rules and policies that may even decide what is true and what is false within a society or a culture. Whereas our subordinate groups are often the groups within society that are marginalized. I also just want to briefly give the definition of implicit and explicit bias. Many of us are very familiar with these definitions, but I think it's always good to refresh. Implicit bias is our unconscious attitudes that lie below the surface and outside our awareness. And they may be in direct contradiction to what you actually believe, but it does sometimes inform your interactions and behaviors, whether you're aware of it or not. Explicit bias, on the other hand, are attitudes and beliefs that we consciously have about someone, a group, a community. These biases inform our behaviors are conducted with intent. You decide with explicit bias if you are going to share those biases with people and let those inform your opinions. I think a lot of people might be familiar with the Harvard's implicit association test, but I think it's a really good resource, especially if you haven't done the test before. It is a long-running research project by Harvard that asks you to group specific attributes to different groups. As you can see, they offer a long list of groups that we may hold implicit bias towards. And the best thing about this resource, I believe, is that you really can wrestle with what you may learn about yourself. And I think it really does surprise people every time they take it that they hold these implicit biases, because you're very unaware of them. But this kind of shows you in a pretty easy way that, maybe you do lean towards this one group. So it does make you aware of what you believe. So the next learning objective is I will understand the importance of cultural humility within maternal child health populations. I'm going to preface that throughout the rest of this presentation, we will be using Mentimeter for questions to the audience. So to participate, you will go to menti.com and enter this code, the 1800 1485, or you can scan the QR code, and I believe it still does ask you for that code. I will be sharing this every single time we have a Mentimeter question. So if you don't do it right now, that is fine. The next slide will also have the information to participate. I think the nice thing about Mentimeter is it doesn't require you to speak out loud during the presentation, and it's completely anonymous. So I hope that everyone will participate. So why is it important that we use cultural humility in our work? Well, because our own lived experience colors how we view the world and others. So I want you to kind of reflect and think about what group identities do you hold? And so we will be doing a Mentimeter word cloud here. And you can join us on menti.com and enter this code, or you can scan this QR code if you want to use this on an external device as well. I will be sharing my screen of the Menti just to show the results.
We see responses coming in. So far, we see group identities that include geography, like Midwestern, race, like white, Caucasian, occupational, like employed, social worker, sex, we have female, male. It's moving pretty quickly, so try not to get dizzy as I'm reading. Roles in our family, like daughter, mother. We have Indigenous, Black, nurse, multiracial, education status, like master's, college educated, a few people saying hello. Hello to all of you. So these are great examples of group identities that we hold. I see religious affiliation, Christian, class, middle class, Anishinaabe, parent. We have political leaning, liberal. We have status of being a friend, and that's 29 responses. Again, if you are unable to join yet, you can just go to menti.com on your computer browser or on your phone and enter the code 1800-1485. And we would love to have all of you participate. It's a really great tool for helping get a sense of the audience and gives us sort of real information to work with as we're giving content. And then I also see age in there, 30, sister, daughter, wife. Okay.
Well,
So
thank
go
you
ahead and
everyone
keep
for
giving those in. Thank you.
participating.
Go ahead.
Yeah, thank you everyone for participating. We will be having a couple more questions like this. So if you want to keep this tab up, we will be changing the slides throughout so the code stays the same. You don't have to keep changing. All right, so as we saw, there is many group identities that shape who we are and how we go about interacting in our day-to-day life. And we're going to go right back to Mentimeter. And so I want you to consider if there are any parts of your group identity that you think may have provided you now or in the past more access to resources, influence, or safety in comparison to people who are not part of the group. So the question's a little bit different on the slide, but I want you to consider the groups who might be considered dominant in culture and that does provide more access to resource and influence and safety. And I will go ahead and share that screen again as we change that slide. And I am participating right along with you guys.
And if you're not seeing the new slide, go ahead and refresh your page. We have lots of responses coming in, but many more participants yet who have not weighed in. If you're just joining us, or if you have not yet, you can go to menti.com and enter the code 1800-1485 to join us. Just give it another moment. So we are seeing statuses that people are reflecting on having provided them in some way, probably better access to resources, influence, or safety in our society. And we are seeing that people are identifying being white or Caucasian. They are identifying being American as an advantage. I see both genders, male and female. So depending on your context, where that provides you better access. Being employed, having an income, the higher social classes, middle class or upper class, or having a higher income, seeing having an education, having a college degree, being seen as something that is provided advantage. Role, such as being a supervisor, that provides you more influence. So the education levels, the race, citizenship, class, gender, employment status. So these are all great examples of group identities that when you are part of one group that is having better access to resources, influence, and safety, that these affiliations provide you access to sort of being part of the dominant culture. And as Danielle, I think we'll talk more about, influencing the perspectives that you bring when you are working with others. So reflection will be one of the things that is part of cultural humility. Thank you for participating.
Yes, thank you everyone. And I don't think we have any Mentimeter slides for a little bit. So if you need to close those tabs, you can keep those tabs open. We do have another question later on in the presentation. All right. So cultural humility within our MCH populations. We work with a diverse group of people, including but not limited to those of different race, ethnic backgrounds, sexual orientation, different family structures, religious backgrounds, genders, etc. And as we just did in that Menti before, we know what parts, at least in our culture, might be seen as more dominant, more safe, more influence, more resources. The important thing is that within our work, we should never assume about the individuals, families, groups, or communities we work with. This is why it's so important to ask questions if you are unsure. That way, we know it's also really important that communities are included in our decision-making processes. We will not know if things are correct or the best fitting unless we ask. So our goal within our work should be to meet where people are at, or the people that we work with. Sometimes we have to make compromises and sometimes we have to take baby steps. Sometimes we're not really ready for that big move. I mean, as much as we are passionate and excited about the work we do, it's also important to understand when to kind of reel back and reflect on, is this going to accomplish the goals I want to accomplish? Without a mindset of cultural humility, it is likely that our discussions, our interventions, and our programs will fail, no matter how good our intentions may be. And as I said, we can be as passionate as we want to be, but our discussions and our interventions and our programs have to be applicable to the people we are working with. It is important for us to acknowledge where our own biases, privilege, and power lies and wrestle with how that forms our opinions, our actions, and how we communicate with others. Acknowledgement, reflection, and action is how cultural humility is used to challenge our preconceived notions based on what our larger societal identities tell us. And then our next learning objective today will be, I will learn of ways that cultural humility has been practiced within the MCH field. So I wanted to share just a couple articles that were brought to my attention by Dr. Ramona Danielson, and they're lovely stories about how people have incorporated cultural humility into their work and how they have used the idea of cultural humility to kind of spread that awareness to others. So I want to share this article called "The Midwife on a Mission to Revitalize Indigenous Birthing Practices." And it is a story about Rebecca Dunlap, who, after giving birth in 2007, sought out the birthing and lactation practices of her Ojibwe roots that had been erased through her grandmother's boarding school experiences. Not only did she want to inform herself, but she wanted to help bring these practices back into her community and to the hospital when people could not have at-home births. And even though as a doula, she had witnessed the microaggressions and biases in the healthcare setting, she sought to educate providers about traditional birthing practices and rituals and advocate for her patients in these settings. And some of the really amazing things she did within her work is she was actually able to have 2 Duluth hospitals welcome American Indian and Alaskan Native patients with culturally appropriate artwork and signs that were in their primary languages. And she also found a way to allow the burning of sacred medicines to their culture with the appropriate maintenance staff. You know, fires are kind of a big deal, or lighting things can be a big deal in the hospital, but she had found a way to make it so that people could do this during their birthing practices. And she continues to advocate not only for her clients as a doula, but as a leader in the anti-racist community within her own community and outside of it. Her story is really just a strong example of how she used her own connections with her Ojibwe community and respectfully created a space with patients and providers so that both can learn and participate in important birthing practices in non-traditional settings. The next article I wanted to share with you is Supporting Indigenous Families for Improved Health Outcomes. And this is actually written by the CEO of HQ, Scott D. Burns, and it really tells of his own experience of really wanting to help a community, but having to take a step back and really reflect on it. So it starts with him going to a conference that is talking about some of the disparities in the American Indian and Alaskan Native community. And he was really excited and was thinking, well, we can do something in our community about this. So he gets together his board and they're talking about what they want to do. And they decide that what they're going to do is to improve the data collection amongst this group of people. But he goes then to meet with Indigenous stakeholders and, she asked him, well, were there any Indigenous members on this council with your stakeholders when you made this decision? And he had to think and say, no, there wasn't. And so she asked him, well, then how do you know that this is the most important thing for that community right now? And so he really had to take a step back and realize that his organization and himself had made assumptions regarding what the Indigenous community needed and what they wanted. As I said, there was no Indigenous voices when he and the other state health leaders had these discussions and made these decisions. So he really had to reflect on this idea that he needed to listen to the community and let go of that power he holds in that community. So within his article, he also gives 3 strategies presented to support Indigenous communities. So his first one was to bring your understanding and education and ultimately your actions into alignment with your eagerness to help. As I have said multiple times, we can be very passionate about something, but we only know so much, and it's really important that we really go through our non-dominant bodies of knowledge and we speak to the community to understand what might be going on in that community, what things that we can do to help it. His second thing was to take steps to facilitate genuine relationships with tribal communities. It is great that he wanted to do this, but in order to go into a community and collect data and be accepted there is to really form a genuine relationship with the leaders in that community, with the people in that community. People might be taken aback if you just come in and say, hey, I want to ask you a bunch of survey questions. They might not take to it kindly when they don't know who you are and you don't know who they are. And then his last strategy was to make space at the table in all senses. And I really love to interpret this one as you, in every part of the decision-making process, and as you are implementing a program or implementing some type of intervention, there should always be someone there who is part of that community, or whoever you are working with, the family, even an individual, they should be a part of that. They should be a part of your decision making. They need to be part of your intervention making, and then also the evaluation methods, if you are able to do those as well. They should be a part of it all. And then lastly, today we will be covering how to practice cultural humility within our maternal and child health populations and with our clients. So just to start out with, a big thing is our communication strategies. Think about if you are able to speak to others in their preferred or primary language. And if you personally can't speak to them in their preferred or primary language, are there interpreters available for you to do so? And then do you have communication strategies for those who are differently abled, such as those who are deaf, who are hard of hearing, blind, or might have different developmental needs and tools? And then thinking about your written communication, do you provide resources in a multitude of ways that acknowledge the different reading levels and comprehension in different languages or for people who are differently abled? And also, and this goes along with communication strategies, using inclusive and person-first language. We should always use people's preferred names, pronouns, and gender. And if you don't know, it is always safe to ask. You should make people feel as comfortable as possible when you are working with them. You should use person-first language when it is appropriate. This is very nuanced, and some people strongly identified and are proud of their status. So it's always okay to ask, would you prefer I refer to you this way or this way? And then using language that does not assume an education level, specific vocation, and heteronormativity. So really trying to avoid using jargon in your field or speaking on a level that really accentuates your power imbalance. We should try to move away from that as much as possible. Make your language easy enough to understand if you were talking to anybody. And then I also want to cover the 5 R's of cultural humility, because I think this is a really, really neat tool and something that's a little bit easier to remember to just think about in your encounters and after your encounters. So the 5 R's are a coaching tool that can be used individually or within your groups or organizations to reflect and assess encounters. This tool helps to bring awareness to implicit bias, and it helps improve relationships between clients and providers. And so those 5 R's are reflection, respect, regard, relevance, and resiliency. And I will go into more detail of each one. And how these are set up, as you'll see on this next slide, is by the aim and then how you ask yourself if you accomplish this. So the first one is reflection. So the aim of reflection is to approach every encounter with humility and understanding that there is always something to learn from everyone. So it is important to ask after your encounters, what did I learn from each person in that encounter? The next is respect. And our aim with respect is to treat every person with the utmost respect and strive to preserve dignity at all times. You should ask yourself, did I treat everyone involved in that encounter respectfully? The next is regard. So our aim with regard is to hold every person in their highest regard and be aware of and not allow unconscious or implicit biases to interfere in your interactions. So you can ask yourself, did unconscious or implicit bias drive this interaction? And this might be a little bit of a harder one, but being able to kind of be aware that implicit bias exists and kind of noticing those implicit biases will help you improve on making sure those don't control your encounters. The next R is relevance. And the aim of relevance is to expect cultural humility is to be relevant and apply this practice to every single encounter. So you should ask yourself, how was cultural humility relevant in this encounter? The nice thing about cultural humility is it doesn't have to stop at work. You can use it outside and within your interactions with other people. It doesn't have to just be work. So think about it being relevant in everything you do. And then the last is resiliency. And the aim of resiliency is to embody the practice of cultural humility to enhance personal resiliency and global compassion. So you should ask yourself, how was my personal resiliency affected by this interaction? And I think this is what also makes the 5 R's of cultural humility so nice, is that it doesn't just think about others, but they want you to also think about yourself. Burnout is very real in a lot of our fields. So being able to ask yourself, was I really affected by this encounter? Do I need to take a step back and just kind of think about how that encounter went? Maybe what could have been done better? We all do very emotionally charged work, and every once in a while it does get to you. So that is why resiliency is also very important. So I want to share, this is a bit of a longer video, it's 8 minutes. And while you're watching this video, I want you to think about how Caroline is encouraging Ashley to look at these 5 R's of cultural humility. It might seem a little bit hurtful at the beginning, so bear with me, it does get a little bit better. So we will go ahead and play that.
I just want to verify when her last appointment was. So she missed 1 appointment or, okay, 2. Wow, thanks. You too.
Ashley,
Oh, hi.
are you okay?
I'm fine. It's been such a rough day. I just got back from a tough home visit. What's up?
I was just stopping by to give you back this file. Do you have a moment to talk about the home visit?
Yeah, sure.
So tell me what's going on.
I had a home visit with a client who recently stopped coming to the outpatient treatment program for opioid addiction. I drove over an hour to meet with this woman. I step into her trailer and she won't even look me in the eyes. All she gives me are one-word answers and everything is a mess. She stopped taking buprenorphine, missed her last 2 appointments that I set up for her here, and it's pretty clear to me that she's still using. Oh, it's so frustrating working with addicts. I just don't know how to get through to her. All I want is for her baby to be born healthy. I'm trying to get this woman treatment so she'll have the chance to keep custody of her child, but she doesn't care.
Okay, I can tell this is upsetting, and I know it's difficult working with individuals with opioid addictions. Some of your colleagues have shared similar frustrations, but I think there's more here we need to discuss. Now, we will have to get to our team meeting, but I'd like to schedule some time to talk more. When is your next meeting?
Next week on Wednesday.
Okay, let's try to check in before then.
Sure, thanks.
Let's see how Ashley and Caroline's next conversation goes.
Ashley, I was concerned about the conversation we had earlier this week about your home visit. I know work is hectic for everyone, but I want you to know that I hear your frustrations.
Thanks. I think I was just having a bad day.
Maybe, but I want to help you improve your relationship with this client.
I appreciate that, but I don't know if this one client is the problem. I think I'm overwhelmed. When I started working here, I didn't expect to deal with the opioid crisis 24/7, but now I feel like it's all I do. I've worked with clients who face tough situations before, but usually working with pregnant women and new mothers is more hopeful. I mean, they want what's best for their children, you know? It's incredibly frustrating to work with a client who seems like they don't care about the future and have no interest in changing, even when their unborn baby's health is at stake.
Tell me a little more about why you think this client does not have any interest in changing. What social or environmental barriers have you considered that may be affecting her adherence to treatment?
I got the impression that she didn't care about anything as soon as I stepped inside her trailer. Everything was dirty and broken, no effort to clean up or fix anything. She was so detached and avoidant. And I've considered that her lack of stable housing and reliable transportation may be barriers for her, but I'm not confident that even if we found her a reliable mode of transportation, that she's interested in getting any help. I just wish she cared.
Let's take a step back for a second. It seems to me that you are making some assumptions about your client based on her socioeconomic status. This may be affecting your ability to understand the factors that are preventing your client from maintaining a healthy pregnancy. Have you noticed any class differences between you and your client? How do you feel about that?
Well, I don't think that's a factor. I'm used to that. Okay, I'll admit that I don't know what it's like to walk in her shoes. And maybe I made some assumptions that I shouldn't have based on what her home is like. But I want so badly for her to have a healthy pregnancy, and I can't understand why she doesn't seem to want that for herself.
So is that where your frustration is coming from? You want your client to have a healthy pregnancy, but she doesn't want it for herself?
I think so. I really value those who care for others, so it's really hard for me to work with someone who resists treatment and harms her baby. It makes me think she's being selfish. I just can't help but feel like she's wasting my time.
Ashley, you are working with a client whose actions contrast sharply with your values, so meeting her where she's at is challenging for you. But I also know that you are incredibly caring and capable of understanding and working with this client.
I want to help her. I'm just not sure what to do.
It's important to be aware of our unexamined biases. Our society often sees poverty and addiction as moral failures, and even though we know better, we may still hold implicit biases. To prevent blaming the victim, it's important for you to understand how your client's difficulty in adhering to treatment, her living conditions, and her attitude towards you are informed by her ecological context. I want you to try to keep working with this client a little longer. Be aware of the biases that may emerge as you're working with her.
Okay.
Ashley, I know you are passionate about the work that you do and that you want your client to have a healthy pregnancy. But right now, it's also important to focus on understanding your client and understanding the challenges she faces.
Okay, I'll try to do that. I'll let you know how the next visit goes.
After Ashley's next home visit, she meets with Caroline again. Let's see how their conversation goes.
How did your last home visit go?
It was better than before. I'm concerned she's still using, but during this visit I tried to get a grip on my judgmental thinking, examine my countertransference, and let her lead. I can honestly say she was more open in discussing her triggers with me than before.
I think you're onto something. Taking a step back and recognizing our limitations is important. If you're open to it, I would suggest that you take some time to discuss your feelings with your coworkers who work with clients who use opioids. I will also continue to work with you until you feel more comfortable working with this client.
Thanks. I really appreciate that.
Of course, this work is challenging. It's not always easy facing our biases, but we must remain open-minded. We are in a continuous process of understanding ourselves and understanding how to best serve our clients.
All right. So after watching this video, I want you to think about which of the 5 R's of cultural humility did Caroline encourage Ashley to consider in her work with the pregnant women experiencing opiate addiction issues. And so this will be a choose all that apply Menti question. So just a reminder that our 5 R's are reflection, respect, regard, relevance, and resiliency. And so if you want to head back to menti.com with the same code 1-800-1485 or scan the QR code.
We'll give another minute as responses are coming in. We're at 20
Okay.
responses of 48 participants. We'll give another moment for anyone else who's interested in participating in the poll. But I think we definitely see a pattern. Everyone who's responded so far felt that they saw Caroline encouraging reflection to approach every encounter with humility and understanding that there's always something to learn for everyone. Everyone also identified respect, that it's important to be treating every person with the utmost respect and strive to preserve dignity. And was she being respectful? Asking Ashley to consider that. Most people also saw regard. She talked specifically about being aware of and not allowing your unconscious biases to interfere in interactions. Also encouraging her to improve her own practices. So thinking about how she was affected by the interaction and how she could be different, and to enhance her personal resiliency and improve her global compassion. And several people also did see relevance, that it was important for Ashley to be asking herself, was I using cultural humility? Was that relevant to this encounter? And that you can expect cultural humility to be relevant and apply to all of her encounters with clients. And I would like to take a moment. You can either put it in the chat or come off mute and reflect on what you saw in this video, how you saw these 5 R's being used, what you thought was most impactful in terms of how Caroline was encouraging Ashley to practice cultural humility. So specific examples or any kind of moments for you that you saw in this video. Like I said, feel free to put it in the chat as well. I know people can be shy. We'll be giving some time for reflection at the end as well. I do think this video is an excellent demonstration of the important principles of cultural humility. I know that I have met people in Ashley's shoes who are frustrated with their clients and don't feel they're getting through. And as Danielle mentioned, it can contribute to burnout. It's not a matter of saying Ashley should just quit her job because she's no good at it and she's being bigoted. It's how do we encourage Ashley to improve? And so Caroline did an excellent job. We have comment from Sherry. Carolyn demonstrated respect and caring and was non-judgmental towards Ashley when providing feedback. She might have been frustrated, right? Like, oh, I can't believe Ashley's talking like this, but she was very respectful herself. Absolutely. And I know I wasn't going to throw the word reflective supervision, but Jessica did. It's a really good example of how reflective supervision is important. And reflective supervision is exactly what Carolyn was doing. It's about the process of helping others, be attentive to the dynamics of the work that they're doing. And cultural humility, in this case, being a really excellent principle that Caroline was encouraging, but that reflective supervision, for those of you who haven't heard of it, might want to look into it. It really does help burnout and improve the efficacy of the frontline providers and the services that they're providing to our community members. So thank you for comments. And if you have any other comments, you're welcome to put them in the chat.
Thank you. And a couple things I wanted to share with you. The diversity informed tenets. I really love this resource and it's available online, even if you just look them up, but I have included the links as well. These slides will be available to you after this presentation. But they're just a really good resource that is specific to maternal and infant health. And it's a set of 10 strategies that you can use to embed diversity, inclusion, and equity principles into the work that you do. And even I'll just share a couple of them from this resource. So one of them is self-awareness, and that really goes into reflection that we talk about in the 5 R's. Working to acknowledge privilege and combating discrimination within your work. Recognize and respect non-dominant bodies of knowledge. We can learn a lot from a journal article, but we can also learn a lot from people themselves. Honoring diverse family structures, which is a great segue into what we will be learning next week. And supporting families in their preferred language, as we've already talked about. I really recommend this resource. It gives much more in-depth descriptions of what each of them are. And then lastly, I just wanted to share a model that I actually found when I was doing the research for this, which is the cultural humility rainbow. And for me, this is a lot easier because I'm much more of a visual learner. So this really kind of helps me hone in this idea of cultural humility. And so the rays of the rainbow are different perspectives and contexts that can come together. And that is where our cultural conflict is encountered. So you can see in that triangle with the squiggly line the cultural conflict. I want to remind everyone that cultural conflict is neither good or bad. It's a pretty neutral thing. It's really how we choose to act when it occurs that is that leads to positive outcomes or negative outcomes. So when we act with cultural humility, so we ask questions so that we can learn from the person, we're respectful, and we recognize and minimize our power imbalances, and we're flexible and open-minded, we are more likely to come to more positive outcomes than if we are to act with cultural ambivalence and cultural destruction and basically not listening to what that person or community has to say to us. This is when we're more likely to see those negative outcomes. So I just thought I would share this model because I think it's a really good visual reflection of what cultural humility is really all about. And so this is the last slide I have of content, but I do have a couple slides of information. So I want to thank everyone for coming to this Lunch and Learn today. I'm so glad to see such a good turnout for our first one. I do just want to mention that North Dakota State University Public Health offers a range of continuing education opportunities in a much more rigorous context. So we do have our Masters of Public Health program with the subplan in maternal and child health. But the really neat thing about the subplan in maternal and child health is that there's also a certificate option. So you don't have to go in for the full master's. You can just do the maternal and child health subplan, which is a very neat opportunity. So embedded in these slides are some more information regarding our Masters of Public Health program and our public health certificates. We have a couple of them, but I felt like mentioning the maternal and child health one was the most relevant. I do want to make a note of our continuing education credits. So we do have approval for both North Dakota Board of Nursing and North Dakota Board of Social Work. At the very end of the slide, I will provide a QR code that will take you to the post-test for those. And then we will also provide a link in the chat for anyone who's in the live audience. Just a note that within the post-test, you will need to register for your CEUs in order to get your certificate. If you just finish the test without registering for those continuing education credits, you will not receive the certificate. So please make sure you are filling that out and going back and finishing the exam. And then after passing this post-test, your certificate will be available through your email for your own record keepings for your licensure and things. We are also offering just plain old, just regular continuing education credits for those of you who are not licensed nurses or licensed social work, but still want that recognition for that training. And so we are also doing digital badging for these. So I did want to just share a little bit of information on what badging is if you are not familiar. So our badges are official recognition of training, skills, and competencies in specific content areas. For this will be specific to the Maternal and Child Health Lunch and Learn series. So why do we get digital badges, or why is it an opportunity to get one? This is a way to show your colleagues and your organizations of achievements and acquired skills. And they can be added to your email signatures and your LinkedIn profiles. And then this registration is also within the same QR code as the post-test. We do ask that you complete the post-test for the badging opportunity as well. I will note that even though our continuing education credits are free, our badging is not. The badging does have a fee of $15. So I just like you to keep that in mind and let people know about that. So I would like to give everyone the post-test opportunity. If you want to scan this QR code or follow the link that Dr. Danielson will be providing in chat. This will be for 0.1 CEU. This translates to 1 contact hour for the North Dakota Board of Nursing and North Dakota Board of Social Work, or you can get that certificate for 1 contact hour, 0.1 CEU. And then also the registration for badging is also within this link. Me and Dr. Danielson will stay online if there's any questions. If you don't want to ask out loud but want to direct message one of us on Zoom, feel free to. This is the first time we're doing this. This is the first one, so there might be questions about the registration and everything. I'd like to thank everyone again for coming today. It has been such a wonderful turnout. And I would like to thank Dr. Ramona Danielson for all her help with this, and North Dakota Health and Human Services for all their help in making this possible as well. Thank you.
And I wanted to thank you, Danielle. Terrific job. Really looking forward to the next 3. And I wanted to let you know that if you didn't catch the full session, or if you think that colleagues would benefit from this presentation and the next 3 will all be available on the North Dakota Train website. You can get a free account to view the trainings when they are posted. And when you look at the schedule for the additional sessions coming up on the 3rd, 17th, and 24th of September, and one of those doesn't work, you will be able to get access to that webinar through ND Train. And people who are completing all 4 badges will be able to get a badge that represents that you completed the entire Lunch and Learn series. So please let us know if you have any questions. We have a couple minutes here. If you have questions for Danielle, for myself, or about the CEUs, contact hours, badges, and E-Train, etc. And thank you, Michaelan, for your comment as well about the video, that she recognized right away that it wasn't the client that had an issue. Her supervisor almost used motivational interviewing to help her recognize her own implicit biases. And what a great example. Thank you.
Yeah, thank you. I appreciate it. This was really awesome. I enjoyed it. So I look forward to seeing the next session. And have a good day, everybody.
You too.
Thank you.